was a 27-year-old male African student present to me with a pain right hip with stiffness in 6 years. It was insidious, has symptoms at rest, on activity, and also during night. Had difficulty in weight bearing and also has significant limitation of activities of daily living. So there's no history of injury, no history of any temperature or constitutional symptoms, no other comorbidities. On examination, he had an antalgic gait. The right ASI is at a lower level, exaggerated lordosis, but his spine movements are pretty normal. He didn't have any back pain either. And he had significant wasting of the gluteals and the quads. The right leg was short, external rotated, 30 degrees of fixed flexion deformity, and global restriction of movements of the hip. And there's no neurological deficit distally. And that's the operative radiograph.
All right, so anyone on the panel want to tackle this?
Does he have any metabolic bone disease?
No metabolic bone diseases.
He's got a stiff hip. He's got 30-degree flexion contracture on his hip.
Correct.
So who is releasing the iliopsoas on this operation?
What do we think it was? First of all, you think it's old Perthes, or what do you think?
Looks like old Perthes, big head.
It's just not a varicose.
Symptoms were only 6 years.
That's right, yeah. Could be a slipped.
Could be an old slip
as
hard
well.
to tell, right?
Or old Skiffy, yeah.
Anyway, it was early because he's remodeled his acetabulum and it's dysplastic, right? So that's the key point. Yeah.
So definitely this shallow cup with proximal migration and shortening we can see. So my plan was straightforward. The patient, the Google Doc said not to take a CT scan, so he wanted MRI. So we had MRI. It shows a good bone stock, both anterior and posterior columns. So my plan was a straightforward total hip replacement.
Why'd you get an MRI?
He didn't want to get a CT scan.
He wanted a CT scan?
Requested for a CT scan to assess the bone stock.
Why were you worried about his bone stock?
It's a dysplastic type of hip with a shallow acetabulum. I want to see the columns.
Shallow, but it had like it almost had a shelf made for you.
Yeah, correct. That's the reason why I want to present this case. When I opened it up, he didn't have any superior lateral wall. His anterior and posterior walls are pretty good. So there's an intraoperative image which shows almost 50% of the superior lateral wall is uncovered.
So is this making anybody concerned that 50% of the superior wall is uncovered?
No, if the anterior and posterior column is completely intact, and I think you could ream a little bit deeper because the bottom was quite thick.
I think you need to ream deeper.
Yeah.
It has been, I could see the medial wall thoroughly. And after that, when I put my trial in, this is what I see. It's almost 50%. And
okay, so hold on. I want to ask the panel. 50% uncovered superiorly. Would you accept that or no?
I'll be able to accept it because we have a good stability inside it, and we do cover the area with the bone subsequently, but not for the stability purpose.
So would you say that 50% is the upper limit of what you would accept for uncoverage?
Yes.
Nowadays, and obviously with screw supplementation?
I think you should be careful about what you mean by 50%, right? So this to me looks like a triangle of uncovered bone where the anterior and posterior walls are intact. That was Vijay's point, and I agree with him. So if that's the case, I'm not worried about the triangle. I would fix it with screws, but I'm not so worried about the triangle. If the entire 50% of the cup is uncovered, then you can't accept that. You got to either use a femoral head autograft, which you could do here, or an augment if you have to in a revision.
the papers which suggest that more than 30% loss of superior lateral wall, the risk of early collapse is high.
It's not the superlateral wall. It's not the superlateral. It's the whole host bone contact. Yeah. So you got anterior, posterior, inferior contact. You got some loss posterior superiorly. That you can go 50%. Just referring to the posterior superior wall. Doesn't matter.
Okay. If you had a doubt, probably you can go for a highly porous coated cup. Just.
Looks like he's putting an autograft on there. It looks like, right?
So you took some femoral head autograft, right? And you made
autograft. It's autograft. The femoral head autograft.
Does anyone think that's going to add anything to fixation?
Well, in dysplastic patients where you really have true bad deficiency, it works great.
Yeah.
We know it works well to provide immediate stability, and it works well because it remodels and enhances bone stock. I can't tell here, but my guess here is you might have been okay without it, but you know, it's hard to say.
Right. Well, I mean, how much initial implant stability you have. And if you have 100% implant stability, which I suspect you do, then that graft is probably not going to even see load, and it probably won't.
There wasn't 100% stability.
Okay.
Rimmed up to 47, put a trial 48. With the trial 48, there was a bit of a tilt going superiorly.
Okay.
So that's why I went for autograft.
Okay.
And that's a cup after the fixation, and that was pretty stable, 48 cup, and that's 3 months post-op. Patient is happy, no issues.
Looks good.
Looks very good.
The center of rotation is back to where it is supposed to be.
But but
Length is perfect.
even the 2, 3, 4 more millimeters up and in, you could probably go and get just that much more fit.
He's a young patient, 27-year-old. He wants to do a lot of activities. I don't want to take any chance. That's where.
Hey, good job.
Looks good. And I mean, you are on the medial wall, as you said. So, I mean, realistically, unless you're going to perforate the medial wall, you couldn't have gone much more medial. If you go higher, there's some disadvantages. So I think this looks great. Good job.
Thank you.
As a tool, we could use a robot here because it tells us exactly where we can put the cup and it's to guide us there. Of course, it can be done very well without it, but it's a good tool for this kind of a case.
Absolutely. All right. Excellent. Well done.
Thank you.